Okay, I'd like to welcome everyone to our webinar tonight, Neoadjuvant Therapy for GI Malignancies, sponsored by the Commission on Cancer, the Florida chapter, the American College of Surgeons. My name is John Rioux. I'll be serving as tonight's moderator. I'm the Cancer Liaison State Chair and also the Chair of the Florida chapter's COC committee. So first, a few housekeeping items. The webinar is eligible for AMA 1 PRA Category 1 credits for 1 hour, the American Board of Surgery Continuous Certification Self-Assessment Credit. At the end of the webinar, you'll be automatically directed to the claim page where you'll be prompted to take a short post-test and then fill out the activity evaluation. This will be in order to generate your CME certificate. You will also be emailed the evaluation link after the webinar. The deadline to claim credit is June 15th, 2020. The objective for tonight's webinar is to discuss the new developments in neoadjuvant treatment of cancer of the esophagus and of the stomach. So joining me as faculty tonight are Ziad Awad, MD FACS, Associate Professor, Department of Surgery, Division of General Surgery, UF Health Jacksonville, in Jacksonville. And Jose Pimiento, MD FACS, Associate Professor at the Moffitt Cancer Center in Tampa. So we're going to take questions immediately following Dr. Pimiento's talk. So we'll hold the questions until both lectures have been delivered. And you can type those in the Q&A box to the right of your screen. And we'll try to respond to as many of those questions as we can. So without further ado, we'll start with Dr. Awad, and I'll ask Dr. Pimiento to just after Dr. Awad is finished to, once we get his slides pulled up, to do what Dr. Awad will do, which is to begin with a little introduction of themselves and what their main interests are in their field of surgery, and then they'll launch on into their lectures. So Ziad, you ready?
Thank you, John. Thank you, Amber. Good evening to everybody. Thank you for the opportunity to talk tonight. My name is Ziad Awad. I serve as the Chief of Division of General Surgery and Surgical Oncology at University of Florida College of Medicine in Jacksonville. My area of interest is esophageal cancer and HPB surgery. And I'm going to give 20 minutes talk about the role of neoadjuvant treatment in esophageal cancer. And I'll go over a few things, some statistics and minor details about the disease itself and the staging and so forth. I have nothing to disclose. This is a slide from the SEER data looking at the estimated new cancer of the esophagus for 2020, and it's probably around 18,500. However, if you look below, the estimated death in 2020 is 16,170. So it's a pretty brutal disease. And at the right of the slide, you can see here, again, this is from the SEER data, the 5-year relative survival is 20%. And I can tell you, we have not made a lot of progress in the last few years with this disease. Again, this slide is from the SEER data. And for those with localized disease, the 5-year relative survival is in the region of 45 to 50%. And with regional disease is in the region of 25%. And this is really goes along with the 5-year survival data of those patients treated with curative intent in the literature. So it depends on the data you follow and you look at it. The numbers are the same. Actually, one of the things that had evolved over the last 15 years, in my mind, is number one, staging. Number two, the role of neoadjuvant treatment. And number three, minimal invasive esophagectomy. And the staging is really, I think, the cornerstone of what we do in cancer surgery. And for cancer of the esophagus, we ought to have three modalities. Number one, good endoscopic ultrasound. Number 2, high resolution CT scan. And number 3, PET scan. And there's a role for each one of them. In fairness, like a good resolution CT scan would look at whether the aorta is involved, whether the bronchus is involved, the vertebrae, that you cannot tell just by the generic CT scan without contrast, or by EUS, nor by PET scan. PET scan, it has significant role in detecting occult metastases, which could happen in 20% of cases. And we see this not only with esophagus, but with pancreas especially. And then the other advantage of the PET scan is that we learn from the rectal cancer experience is really assess response to therapy, whether the cancer is responsive to therapy or not, and whether the patient is a responder or not. And this will have implications in the treatment planning, because if the patient is non-responder, then the question is, do you really want to operate on this patient? Endoscopic ultrasound, or EUS, is an excellent modality to look at the T status of the disease, i.e. the depth of the cancer. There are some difficulties in defining the role of endoscopic ultrasound, especially for T1 disease. And you need to have a good EUS person who can look at the difference between T1A disease and T1B disease, because the difference is just a submucosa. So you need to have a good EUS person to give you the answer, because the treatment is significantly different between the two of them. The other areas of difficulty of EUS is after neoadjuvant treatment, and those patients with tight strictures. If you look at the AJCC 8th edition and definition of early esophageal cancer, it usually falls into T1A and T1B disease. However, the treatment is very different between the two groups. For T1A disease, those who are considered intramucosal adenocarcinoma, we do a variety of non-surgical intervention, mainly argon beam, laser, photodynamic therapy, EMR, ESDs, RFAs, cryo, name it. However, 20 years ago, there was a lot of esophagectomies done for this early disease, but not now. There is no doubt if a patient has a T1B disease, this patient will go straight to esophagectomy. The only exception, if the patient refusal or he is not a good surgical candidate. T2 disease, that's another very controversial topic. A lot been talked about, and I don't think any two esophageal surgeons would agree on how to deal with these patients. If you look at the data from Don Lowe at Virginia Mason, they found that 60% of the patients were overstaged and 40% are understaged. So there is a consensus that usually offer the patient an esophagectomy and then consider adjuvant treatment only for those who have node-positive disease. Although personally, I prefer to give patients upfront treatment for T2 disease. And this is the look at the NCCN guidelines looking at the T2 disease. If I would just highlight it here, and they emphasize that the lesion has to be low-risk lesion, less than 2 cm, well differentiated, i.e. if you have a big circumferential lesion that's poorly differentiated, then you ought to consider neoadjuvant treatment. This is where the main topic of the night is neoadjuvant therapy. For those of us who deal with cancer, we are doing more and more of that, mainly for esophageal, gastric, and pancreas. And the reason for this is it's easier to give the patient upfront treatment versus on the back end. And the primary goal of the neoadjuvant treatment is really improve overall survival. And the secondary endpoints are local tumor control and then lengthening the time to recurrence. And if you look at for esophageal cancer, there are two schools of thought as neoadjuvant chemotherapy and neoadjuvant chemoradiation. I'm going to start with this slide. It's a bit complicated, but I'll just try to go through it systematically, looking at the role of neoadjuvant chemo. And usually most of the initial trials started in the UK. The first one is by the intergroup, where they look at patients with esophageal cancer receiving cisplatin 5-FU, and the initial study actually did not show any survival benefit from neoadjuvant chemotherapy. The next study from the UK came from the Medical Research Council, the MRC, and these looked at surgery arm versus 5-FU cisplatin, but that time showed significant survival advantage and significant R0 resection. So it's the way that both studies were conducted were a bit different, and the MRC was more well-structured study. Now the MAGIC trial, which is number 3, this is where it gained a lot of interest and fame, where they looked at patients with G-junction, gastric, and esophageal. As a matter of fact, 25% of the patients were G-junction and lower esophageal. And they started with ECF, which is epirubicin, cisplatin, 5-FU, 3 cycles, 3 weeks apart. Then they give the patient 1 month break, then 3 cycles afterwards. And this has shown significant 5-year survival advantage and progression-free survival. And this has actually put this study on the map, that it's the more or less the standard of care. But if you dig deep into it, although this is not the place to talk about this, there is some flaws in it in terms of follow-up and the staging parameters they used. The FFCD study that came from France, and again, they used preoperative cisplatin 5-FU versus surgery arm only, and showed significant 5-year overall survival, disease-free survival, and R0 resections. The Japanese Consortium of Oncology, they decided to use preoperative versus postoperative 5-FU cisplatin, but there was minimal, if not advantage, and the toxicity was a bit higher with the postoperative 5-FU cisplatin. And then Anderson from the MRC from the UK, they compared, which is actually an excellent study, looking at preoperative 5-FU cisplatin versus ECX, which is ipirubicin, cisplatin, and Xeloda, and showed that the significant advantage with there was no significant advantage in any one of them, and they questioned the role of the ipirubicin. The toxicity was a bit higher, but there was no difference in the overall survival between 2 arms. The last study for the neoadjuvant chemo is the FLOT4. This is a very famous study because they looked at comparing ECF, ECX versus the docetaxel, oxaliplatin, 5-FU, and leucovorin. This showed significant 5-year survival advantage for the FLOT. So we usually give the FLOT 4 cycles before surgery, and then 4 cycles afterwards. And this is more or less the study used more frequently now for gastric cancer, but it can be used in G-junction cancers because nearly 60% of the patients in that study were esophageal cancer. Let's hop to the other modality of neoadjuvant. I'm going to skip the slide. We got to go to the neoadjuvant chemoradiation arm. And this is more interesting because the first study came from actually Ireland, from St. James's Hospital. Tom Walsh and Professor Hennessy, which is a big unit in the Republic of Ireland, and they compared neoadjuvant chemo-XRT 5-FU cisplatin with 40 grays versus surgery only. And actually, there was significant advantage in the median survival of 16 months versus 11 months. However, the study was really criticized because the follow-up was 10 months, and there was a lot of violation in the protocol, and the low survival in the surgery arm, barely 11 months. And the next study is the EORTC, where they looked at patients with squamous cell carcinoma of the esophagus. If you look at the design of the study, was very, very convoluted. The radiation protocol was done like 2 one-weekly courses, and they were 2 weeks apart. And the daily fraction was 3.7 grays, which is very, very high dose per day for radiation. And even though the pathological complete response was in the region of 20%, but the trial was stopped because there were significant mortality in the neoadjuvant chemo XRT arm, because they were given 3.7 gray per session, and this is considered high. Our colleagues from Australia, came up with the Trans-Tasman Radiation Oncology Group and the Australian Gastrointestinal Trial Group. They randomized patients with esophageal cancer, both SCC and adenocarcinoma, into surgery arm versus neoadjuvant chemo-XRT using cisplatin monotherapy and 35 grays of radiation. And not surprisingly, the study failed to show any survival advantage for 2 reasons. Number one, they used monotherapy. Number two, the radiation dose was not adequate. The last study, which is actually now is the gold standard or the Bible, is the cross study from the Netherlands. The initial trial was published in 2012, and further follow-up was published in Lancet Oncology 4 years ago. And they're looking at patients with esophageal cancer, both adenocarcinoma and SCC, and they neoadjuvant chemo XRT, carbotaxol, and then that's weekly carbotaxol, and then 41 grays. And this study has shown unequivocally excellent 5-year survival with the neoadjuvant chemo XRT arm compared to the surgery arm, as well as significant improvement in the median overall survival for both pathologies. And this is here Kaplan-Meier look at on the left side here for the neoadjuvant chemo XRT arm plus surgery versus surgery alone. And there is significant survival advantage. And then on the right slide, this is pertaining to the pathology type, i.e. the survival advantage was distributed or well in adenocarcinoma and SCCs. And this is the long-term data that was published actually in Lancet Oncology. It showed significant advantage of the neoadjuvant chemo XRT, i.e. carbotaxol plus radiation followed by surgery. I am going to touch on one topic, then I think my time will be up, is this is a question we always ask about, is the timing of esophagectomy after neoadjuvant treatment. And I have to quote two studies. One is from our colleague Wayne Hofstetter from MD Anderson, and they found that to delay surgery beyond 8 weeks really did not make a difference in the technical difficulties or overall complication rates. And then the sub-analysis from the cross trial for those who were delayed time to surgery, slight increase in the probability of postoperative complications, but without affecting disease-free survival and overall survival. And this is, they looked at the slide here, and I mean, for those who, even though the number was low, but they did not find any difference in the complication rates between the two groups. I don't want to labor this anymore. I think I can go on for another 2 hours, but my colleague Jose will be following me with probably a more interesting topic than this, which is gastric cancer. Thank you very much for the opportunity.
Very good, Ziad. That was very interesting.
Thank you.
Get Dr. Pimiento's slides up. You can be writing your questions down at home, or you can even put them in the chat box. But let's go on, Jose.
I'm glad that you didn't take 2 hours yet. That was great, but it was a really amazing topic. We're going to move a little forward down the GI track to the stomach. My name is Jose Pimiento. I'm the section leader of the upper gastrointestinal oncology program at the Moffitt Cancer Center. And I have nothing to disclose as it relates to this conference. This is the outline of what we're talking about. Again, the obligated epidemiology slide. Then we're going to be talking a little bit about the workup and staging, and we're going to focus on laparoscopy and what is important to understand which patients need neoadjuvant therapy. Then we're going to be talking about the role of chemotherapy, focusing in 2 landmark trials, the MAGIC and the FLOOD4. Already you have heard some about it. The role of radiation, and we're going to talk briefly 3 trials. However, you'll figure out that they are adjuvant trials, not neoadjuvant, so I'll try to talk a little bit about it. And finally, we'll talk, if time permits, something about the molecular advances that we're seeing in the last few years. So in regards to epidemiology, about 1.6% of all new cancer cases are gastric cancers, 27,000 people in the US in 2019, and about 11,000 deaths. And as, again, you can imagine, most patients will present with disease that is either local regional or distant, with the survivals that are very low, in the 5% range for the distant cancers, and local regional, about 1 in 3 will survive 5 years. So again, not really good survivals. So it's a very important topic, and we need to do anything that we can do to make the survival better. So you're going to see a bunch of slides from the NCCN, and I will try to explain why are they important. So the first one is to explain what classification we use, and we use the AJCC 8 classification. And the things that we're looking for is, like in every or most cancers, is the TNM classification. N is the number of lymph nodes, and for N1, 2, 3 depends on the number of lymph nodes that are involved, not necessarily the lymph node stations, what we learned years ago in medical school. In regard to metastases, distant metastases, including peritoneal disease, will be called M1. And in regards to the primary tumor, again, we make a break when the tumor invades the muscularis propria. And those are tumors that are considered to be T2 tumors. In the AJCC, again, you can see how the clinical staging is different than the pathologic staging, and is different than post-neoadjuvant therapy staging. And that is very confusing for our patients and for our practitioners, because again, you don't know what stage the patient is unless you have the final pathologic stage. And that depends on the treatment the patient received, because the survival is different depending if they receive treatment or not. This slide didn't project it well, and actually the animation got lost, and I apologize for that. But this is one NCCN slide that will explain the workup that is necessary for these patients. And the workup will include an HMP, an upper GI endoscopy with biopsy to establish the landmarks of the tumor, to define if it's a gastric tumor or an esophageal tumor. A CT scan of the abdomen and pelvis with IV contrast, the same reasons why we discussed in the previous talk. And if we don't see clearly evidence of metastatic disease, we'll be getting PET scan to evaluate for metastatic disease with similar numbers than what was referred for esophageal cancer. The endoscopic ultrasound in gastric cancer is a little different. It will help us define between very early stage disease or later disease. So that breakdown between T1B and T2 tumors or more advanced. And will also help us to define if the lymph nodes are involved, although the false rate of positive and negative disease is higher. But again, we try to use the highest staging by any of the methods previously discussed. So if the US chose lymph node disease, we consider the patient to be nodal disease positive. Moreover, it's important to know that the patients that have more than T2 disease, we will consider to perform a laparoscopy as part of the staging diagnosis. This means we are not going to consider the laparoscopy as a treatment method. We're going to use it to finalize the staging of the patient. And the reason for that is very simple, and is that the patients that have laparoscopy, staging laparoscopy, two things can happen. And this is from a paper from 2006, so it's a little bit old, but was one of the first ones to tell us what laparoscopy could add in the setting of a localized disease on the stomach. So these were patients that had CAT scans and had either tumors of the GE junction or Lenitis plastica versus tumors that were not that were in the body or antrum. So those tumors were divided in the ones that were nodal positive and the ones that were nodal negative. And in nodal positive patients, the staging laparoscopy actually recognized either peritoneal or as a solid organ disease that was occult in a CAT scan in about 70% of patients for Lenitis plastica and in about 30% of patients without a Lenitis plastica. And as you can see, those are the elements that could be associated with finding a positive disease in peritoneum. But it's not just finding gross metastatic disease. Also, in this paper that was published recently, where they look at 1,200 patients, they find out as well that about a third of those patients will have cytology. So about a third of the patients that go laparoscopy with tumors that are more than T2 will have a peritoneal disease only, out of which 2/3 will have visible disease and about a third will have cytology positive disease. Despite being cytology positive disease, the disease-specific survival for those patients was as bad as the disease-specific survival for patients that were outright metastatic. Therefore, this shows us that, again, peritoneal cytology and diagnostic laparoscopy are fundamental for staging these patients. So now we have a patient that has been recognized to have non-metastatic disease because they are laparoscopy positive. And now we have that the patients are T2 or higher, and they can have lymph nodes positive or not. And the recommendation is preoperative chemotherapy, that is the preferred recommendation, or preoperative chemoradiation. So I'm going to try to explain to you what are the trials behind these recommendations, or what is the lack of trials behind this recommendation, and what can come in the future for these patients. So we're going to talk a little bit about the role of chemotherapy for neoadjuvant therapy for gastric cancers. So the first trial, you already heard about it, is landmark trial. It's called the MAGIC trial. You heard thousands of times. This was published in 2006, and the schema is very simple. They found 503 patients that had, by CT scan imaging, T2 disease or higher, or nodal disease positive. They were randomized to receive epiruicin, cisplatin, and infusion of 5-FU versus surgery alone. They received this scheme of treatment, ECF times 3. They recovered from the ECF, they had surgery, and they received some more chemotherapy in the end. The median follow-up was 48 months, and there were a significant portion of patients that were GE junction or gastric cancer patients. They all had great performance status. So the results are striking. There is improvement in 5-year survival from 23 months for surgery alone to 36 months. And this was for many years the standard of care. Multiple other papers came after that, trying to replace ECF as the standard of care using epiruicin and using a 5-FU and cisplatin, showing us decent results, but nothing as good as the FLOT that, again, you heard a little bit about before. And in this trial, the contender, that would be 5-FU, oxaliplatin, leucovorin, and docetaxel, were compared to the standard of care, ECF. The 5-FU was given either as infusion of 5-FU or Sarceloda, and they were given either 4 cycles resection or 4 cycles of float, or 3 cycles of ECF resection and 3 cycles afterwards. The patients had to have T2 disease plus or any nodal positive disease, and it was a large trial with 716 patients, and the primary endpoint was overall survival. And a couple of things out of notice, many patients were CWAR1, the foreesophageal cancers, about 1/3 of those patients. The other ones were more considered proximal gastric or stomach cancers. And interestingly enough, the survival went from 35 months, very, very similar to the MAGIC trial results, to 50 months in the with a new regimen that is FLOT. The 5-year overall survival was 36% versus 45%, again, favoring FLOT, and the same things remain true for the disease-free survival. A couple of things are important to notice, and this is probably the first trial that shows such an important complete response rate, with a 60% complete response rate for patients receiving FLOT. That is about half of what we see with the cross trial for esophageal cancer. The things, however, that are giving us pass for using FLOT for esophageal cancer are related to this slide. The first thing would be the fact that only 85% of patients achieve R0 or complete surgical resection, about 78 in the ECF or ECX group, meaning that 15% of patients had incomplete surgical resection. To put in perspective, the data from cross for esophageal cancer for complete resection is in the 96% range. And second, you see this busy slide, busy table on the right showing all the complications, and you can see how these two regimens are extremely toxic. The mortality rates were not very high, but the patients got sick receiving this treatment. Therefore, the NCCN guidelines will show us that despite having the best evidence for the use of 5-FU, leucovorin, and oxaliplatin, a lot of patients will receive 5-FU and oxaliplatin alone without the addition of the docetaxel, just because it's so difficult to tolerate. Having said that, younger patients, healthier patients will be receiving the triplet therapy. So again, for chemotherapy, either a double therapy, basically FOLFOX, the same or similar treatment what we're receiving for other parts of the GI tract, or if the patient is in better shape and we think that they can tolerate treatment, they'll be FLOT. As 5-FU cisplatin, again, there is category 1 data, not as good as the 2 trials that I showed you before. So I hope the chemotherapy portion is a little clear with all these trials and names. Now we're going to talk about an area that is a little more nebulous, a little harder to understand, and it's the role of radiation therapy in the neoadjuvant setting. And we need to extrapolate a lot for the adjuvant data. Why? Because when you look at the trials, there are none, but we have a lot of retrospective series. And probably the biggest proponent in the US of using neoadjuvant chemoradiation for gastric cancer is the MD Anderson Cancer Center. And this is one of their papers. And what they show over and over is that they see very good results when giving preoperative chemoradiation for the patients with very good prolonged survivals. Having said that, there are no comparison head to head. And the point of today is trying to show you level 1 evidence that will justify the treatment. So we're going to try to go to the adjuvant setting where we have more level 1 data, and if anything, very problematic data of the role of radiation for gastric cancers. Just to give you an idea, we are right now in the molecular alteration and also on their behavior and the targets that could potentially be evaluated. But the most important thing that I want to get you from that is the new understanding that, similar to colon cancer, patients that have microsatellite unstable tumors will not respond well to adjuvant chemotherapy. And this understanding is better expressed in this graph from an analysis from the MAGIC data, where they compare the patients that had chemotherapy and surgery, if you remember the trial that we talked about in the beginning of our talk, and the patients that had microsatellite stable disease or microsatellite unstable low or microsatellite unstable high. So this is microsatellite unstable tumors. That will be the gray one in the top and the yellow one in the bottom. And you can see that the patients that were microsatellite unstable and received only surgery did significantly better than anybody else, showing us that these may be completely different tumors. Moreover, the patients that received chemotherapy and surgery and were microsatellite unstable tumors, they did not very good, showing us that out of everybody else, this subgroup of patients may not benefit from neoadjuvant therapy, and we need to reconsider and recalibrate what we do. They may benefit more from things like immunotherapy, surgery alone, or even radiation. So this is what we could do over 20 minutes. Certainly, I could speak also for about another 2 hours. So it will be like a 5-hour talk. And so instead of doing that, we'll open the space for some questions. And thank you so much for your attention.
Thank you very much, Jose. So if anyone has any questions, they can type them in the chat box off to the side. And while we're waiting, I'd like both of you to kind of weigh in on the fact that it seems like every cancer that we're treating now, there are at least subtypes of those cancers that are being treated with neoadjuvant. And so it seems like we're in a paradigm shift. I mean, even when I was a resident, 25 years ago, we were, treating rectal cancers. Now, of course, that's the only way we do it. And squamous cells of the anus are often completely treated, without surgery. And of course, a lot of the head and neck cancers are treated without surgery. So we're in the middle of this paradigm shift. And based on the meeting that we had under the direction of Dr. Redan, who is on the webinar tonight, the surgeon of 2030, where do you think we're going to be in this paradigm shift in another 10 years? Are there going to be any cancers that surgeons get to first?
I think in 2030, we're going to be dealing with some different circumstance that is going to be maybe a little bit of better understanding of risk and early identification of this tumor with screening protocols. We're going to be better at mathematical modeling of risk factors, for example, Barrett's esophagus, and which patients need more frequent endoscopies than just based on their dysplasia or no dysplasia. Secondly, once you find those tumors early and you exhaust all endoscopic measures, then you're going to still be getting to operate some of those patients early. But the problem that we have is not that we cannot operate on those patients. The problem that we have is that we also understand that there is circulating tumor cells extremely early on the process of oncogenesis. Those tumor cells may not latch onto tissues. Those tumor cells may not be living in the liver. They may not be alive in the liver or in the lungs where we do the operations, but they may be. So our role is to try to find out the patients that are more likely to have tumors that are already stage 4 and we just don't know about them, and try to mitigate that situation, try to exterminate whatever cells are outside of the organ of interest, and getting after that. And there'll be more things that we'll do in early staging just based on screening, but I would doubt that most cancers that have bad prognosis will be treating without neoadjuvant therapies. And that's my 2 cents on that.
I agree with Jose. I mean, this is, I think, like in the next 10 years, we're going to see more genetic sequencing. I think the guys at Hopkins, they're doing a lot of work on the CTAs, circulating tumor cells. Hopefully we'll get somewhere with this. I mean, it's really heartbreaking, like when you do a big operation, then a month later, the patient has liver metastases. So you just like think to yourself, what did I do here? Seriously, if it's me, would I want to have this? Probably not. I think we'll be moving more and more towards neoadjuvant treatment. And I think more science into defining circulating tumor cells, genetic sequencing of these. I mean, not every esophageal cancer is the same. Not every pancreatic cancer is the same. We don't know a lot of it or about it, unfortunately. And I think with more research funding into the cancer data banks, for more research, really should help us a lot.
So Zia, Dr. Redan asks, can you please address the modalities of Ivor Lewis esophagectomy and his experience? They stopped performing robotic esophagectomies. The open has less long-term complications, shorter OR time, and Dr. Redan and Dr. Gargazalou have had a lot of robotic experience, 25 years each. And any thoughts on the learning curve, long-term survival, open versus laparoscopic robotic?
So I don't do robotic esophagectomies. This was never appealing to me. I think I've been doing them laparoscopically for a long time. I think once you've done probably over 100, you can have it down to, your operative time should be the region of 6-7 hours. However, we look at our data now. You need only one morbidly obese patient. This will tip the curve all the way around, So I do them laparoscopically. As I'm getting older, I have very low threshold to open. Actually, the last case we did was done on Monday. On Monday, yes. The guy has a huge belly. I just spent 15 minutes looking at it. I said, I just cannot do it. So I just did an X-lap, So but looking at NSQIP data, the specialized NSQIP data, there is some less pulmonary complications than shorter length of stay with the minimal invasive Ivor Lewis esophagectomy. However, if you have the numbers, if you have a good ICU care, you have a good recovery pathway, I think you can offset this variable.
So we do almost exclusively robotic esophagectomies. We just presented in the last Florida chapter meeting our 350 resection series. And actually our outcomes, we almost exclusively perform robotic. Certainly a big tumor involving require multivisceral organ resection, then that will do it open. Colon interposition, we may do the abdomen open and the chest robotic. But our outcomes, and we compare them to NSQIP and NCDV, aside from PEs were exactly same. The difference is that we do CT scans with IV contrast with our swallows to try to recognize those very small non-clinical anastomotic leaks patients with normal white count. We do them almost exclusively Ivor Lewis unless they need to have anastomosis in the neck. Our median time is just a little longer than open time, and our survival is same than NSQIP and NCDV. So when we match for same stage and the treatment received. So we don't see that you're seeing, and certainly it's a matter of experience, but Dr. Awad is completely correct. All the people that have looked seriously at complication rates express that the time for decreased mortality may be decreased mortality and significant complication, maybe about 120 cases. So that requires a group, that requires support from the institution, and that requires people to do it for a long time. And we are there. Having said that, you can have a leak any operation you do, and then you have 3 in a row. Because this is the nature of the disease, and whoever does esophagectomies and says that they don't leak, probably they are leaking somewhere else, and somebody else is taking care of your complications. But what everybody that does esophagus sees is that these patients are tough to deal with. But our long-term survivals are the same as open, with shorter length of stay, shorter need for pain medication, and at a month out, most of them feel better than historically they did with open surgery.
So we're running a little thin on time, but there's 2 quick questions. Just, is there any neoadjuvant immunotherapy studies that you're aware of? And I know you won't be able to summarize them, but is that something that if it's not done, is on the horizon?
So yes. So there are students trying to especially in patients with EBV and microsatellite unstable tumors, try to either use radiation early and stimulate it with immunotherapy, because we understand that those tumors are more immunogenic. I don't think there is any studies for the neoadjuvant setting. For the adjuvant setting, we have not seen the results on adjuvantly using immunotherapy for people after neoadjuvant therapy and esophagectomies. That should be coming out in the next year or so. But the data, I think, for the adjuvant, I don't think is as good as maybe for target patients with microsatellite unstable or EBV positive tumors.
So the other last question I alluded to was many neoadjuvant treatment patients have R0 resections. Do you think that there's any benefit from performing a huge operation on the patient when there's no cancer left?
So I think the question was more about PAT-CRs. So R0 resection, actually, hopefully all resections are R0. But if we're talking about a complete pathologic response, agree. And nobody knows exactly what the value is doing resection in complete pathologic responses. The problem is what we call complete pathologic response, and that is not seeing any cells. The question is how many slices of tissue do the pathology do to actually find out that they are no cells that are viable in the tumor. But putting that aside, the question right now is that even to the best trial that is out there, that is the ProSano trial from the same people that brought you the Cross trial as an advertisement, the best study was about 85% accurate in identifying patients with quote-unquote PAT-CR, and they included patients with a grade 1 response, meaning still small clusters of tumor cells in the pathology. So I don't think that right now we can find out the patients that are PAT-CR with clinical imaging. I don't think that clinical complete response is attainable yet. I think the false positive rates are just, and the false negative rates are just too high. And I don't know how you feel, Ziad, about it.
Mm-hmm. So there's a data from, I think it was from Japan. It was published in JACS a few years ago. Look at those patients with endoscopy negative biopsy post neoadjuvant. And for those who underwent resection, actually nearly 60% of them showed viable cancer cells. So that was not detected on endoscopy, nor EUS, nor imaging. So I think the only way I can tell the patient that you have a median survival of 12 years is by taking the esophagus out.
Yeah.
And if there's no cancer left, then he's most likely going to live 12 years.
And that is actually what we see with complete with when the pathologist tells us that is PAT-CR, but the only one who can call pathologic complete response is the pathologist.
Correct.
Everybody else, we run between 40 to best case scenario 20% chance of false negatives. And again, when somebody tells you have a 20% chance to miss a cancer, you may act. But if somebody were to tell you opposite, that you have an 80% chance to win the lottery, then you'll buy it. So a lot of people nowadays will refuse to have surgery because of the hope that the cancer is gone. And some of them are right, some of them are wrong. And we know that waiting after surgery, especially more than 3 months out, increase complications. And hopefully doesn't translate in mortality. But when you look at those series of patients that underwent quote unquote salvage esophagectomy, the mortality almost in all of them is about 10%. So it may be because we're only operating late on the people that are really poor performers, or it may be because there is something related to doing chemotherapy and radiation and waiting 6 months to operate on them. I don't know the answer, and I don't think we'll have enough patients to answer that. But I can see that I see weird things when we wait more than 3 to 6 months to do an operation after chemo radiation. And I don't know if that has been your experience as well.
Yeah. Yep.
All right. Well, I'd like to thank everybody for their attendance, and I'd like to thank our presenters, Dr. Awad, Dr. Pimiento, and if anyone has anything else, I don't think so. Thanks and good night.
Awesome.
Thank you very
much.
Thank you. Bye-bye.
Bye.